start with a few announcements, with a few introductions, and just introduce the people in the room, and in case you hear our voices. My name is Fauzia Malik. I manage the Developmental Screening Initiative here in New Mexico, and I'm happy to have here with me Meredith Williams. Dr. Meredith Williams is a pediatrician with Multidisciplinary Early Childhood Evaluation Program, ESEP, at the Center for Development and Disability. This program serves to evaluate children birth to 3 who are impacted by a variety of medical and developmental diagnoses. Dr. Williams has enjoyed traveling on outreach clinics around New Mexico where children may be served in their home community. Dr. Williams is a graduate of the University of New Mexico School of Medicine and completed pediatric residency at University of New Mexico Hospital as well. She is currently an associate professor of pediatrics at UNM Health Sciences Center, and we're happy to have her here and introduce this first module of the ACT curriculum. Please feel free at any point to send us a message or write us a question in the chat box you have in front of you. So I'm going to turn it over to Meredith.
Thank you, Fauzia. Well, I'd like to thank Envision NM DSI for inviting me to facilitate and be your coordinator for this first module of 6 that the CDC has put together in collaboration with some other organizations. The first module is Early Warning Signs of Autism. I think it's really effective. I have a lot of great videos to show you, and I'm just really excited to be here and participating. So thank you all for joining me. As I said, the CDC put this together in collaboration with the National Center on Birth Defects and Developmental Disabilities, and also in partnership with Health Resources and Service Administration, the Maternal and Child Health Bureau. So the case and the handouts that you have with you today are not copyrighted. You're welcome to reproduce them, to hand them out, to use them in your practices, but please do give credit to these organizations if you do so. So I'd really like to start by just talking about why the case we're going to read through is important today. The average age for children to be diagnosed with autism is between 3 and 7 years of age in the United States. And we know that parents have worries about their children's socio-emotional development before that time, usually long before 18 months. So we know that there are risk factors associated with late autism detection, and I know that many of you are signed on from more rural parts of New Mexico, and we do find that kids that live rurally away from the city are often diagnosed a little bit later. And also we have families that seek care from multiple providers, and these kids are also less likely to be picked up on time. The kids we do seem to pick up are those that are fairly, what you might say, classic. They might be kids who flap or toe walk or have some of the more obvious behaviors that we associate with autism. But some of the more subtle first signs are the ones we're going to focus on today. I think all of us have seen the incidence numbers really growing, and there's some great statistics from the CDC that help sort of inform us of the importance of picking up on these early warning signs. 1 in 88 children right now is the number on the CDC webpage. And between 4 and 5 times as many boys are affected as are girls. So for boys, the number I read most recently was 1 in 54, and for girls, 1 in 252. So the reason to detect these kids really early is that we know by evidence-based studies that early intervention can really help these children to gain competency in these areas of need, like helping their long-term outcomes in communication, social interaction, and ability to mainstream into school classrooms. So again, I'm just delighted that all of you are here today. This is my contact information, and you're welcome to email me or call me if questions come up after the presentation or if I can provide resources to you. I just wanted you to have this in your presentation today. So just to review our learning objectives for today, first to identify key social, emotional, and language milestones through 2 years of age. Our case focuses on a 2-year-old, so that's really what we'll be focusing on this afternoon. This includes describing typical social skills, birth through 24 months, expected language milestones from birth through 24 months, and play skills by age. And then secondly, and the sort of the crux today, is to recognize the major early warning signs of autism spectrum disorders, including those key red flags. And there's also a portion on recognizing the difference between sort of typical temper tantrum, terrible 2-year-old behavior, and what is really more pressing in terms of a child with an autism spectrum disorder. I think you have the case in the next slide. What I think is interesting about this case is that the CDC chose to use a family member coming to you for help as the first scenario. And I think as healthcare providers, as early intervention providers, I know there's a spectrum of professions represented today. We often get curbsided by family members or friends when they have a concern about their child. And I think this is really a poignant part of the case that we have to sort of answer these concerns, not just with our knowledge, but also with our heart. And I think it's interesting that they chose it, and hope you guys will have some comments about that on the chat line as well. So I'm going to start by just reading through the case. It's a little bit long, so bear with me. You are attending a family reunion, and during a quiet moment, your cousin Elizabeth takes you aside and asks you what you think about the development of her son, Mark. She tears up as she tells you how worried she is about him. Mark will be 2 years old next month, and he seems so different from the other children on the playground. Although he is an affectionate and happy little boy, his behaviors can be so unpredictable. He is very shy and has terrible temper tantrums. It is usually impossible to reason with him. Small changes in his routine throw Mark off, and Elizabeth is worried that he won't be able to handle the crowd at this family gathering without causing a scene. You ask her what her pediatrician thinks. Elizabeth tells you that Mark has been seen by his pediatrician, and she has expressed her concerns about his temper tantrum on a few visits. The doctor has told her to give him some time. He is still young and will likely grow out of this phase. Mark enjoys going to the doctor's office because they have a large tropical fish tank, and he has generally been calm in that setting. Mark's doctors have all been very reassuring and think he has a bad case of the terrible twos. You've been a bit preoccupied by your relatives, and you honestly haven't been paying too much attention to Mark. You know that your cousin is a doting and caring mother. Elizabeth and her husband Sam had fertility struggles, and she was thrilled to give birth to Mark after a grueling course of in vitro fertilization treatments. You know that Mark was born full-term without any complications. You heard he was a fussy baby, but otherwise helpful. So I'd like to pause for a moment, and hopefully you may have some input about what stands out to you about Elizabeth's concerns for her son, Mark. You're all quiet today.
Quiet
and
muted.
So maybe what we could start with is Elizabeth being concerned about Mark's very shy manner. So let's start by talking about some typical social milestones at these different ages. Sure.
Yeah. So one person indicated the fact that Mark is upset by any change in routine.
So, right. We always want to know about how children are transitioning, and if transitions between environments are difficult for them, or if they're very rigid about how their day is structured or any small change in it. So that's a great observation. Anyone else?
Yeah, there's a couple of people that said she seems quite concerned about the tantrums. Again, the routine issue, changes to the routine, the shyness, temper tantrums.
So, great. So I think those are all really great points, and our job is to sort of tease out whether these are truly typical behaviors or whether they're really limiting Mark's engagement with others and his ability for his mom to take him out and to get through their day.
Another comment that one person made was that he's drawn to the fish tank.
Right. So, again, we would have to tease out some more details about that, but is this a little guy who could spend half an hour looking at this fish tank and then becomes very upset when he's removed from the fish tank? Is this a little guy who's pointing at the fish and showing you the pretty fish and sharing his enjoyment of this fish tank with you, or is he pretty absorbed in isolation with this fish tank? So these are great points from you guys. Okay, let's go on a little bit. And someone brought up that she's concerned about Mark's shyness. And later on in the afternoon, we're going to talk a little bit about shy temperament versus signs of autism. But I'd like to start with this, which is really the key, these typical social milestones at 12, 18, and 24 months. So I think these are very familiar to you, but joint attention at 18 months, which is where a child expresses an enjoyment in sharing an object or event with another person by looking back and forth between the object and the caregiver. So joint attention is one of those critical but very subtle aspects of social interaction that when it is deficiency, it's a real core feature of autism. And I have some great videos to show you exactly what I mean by joint attention. Again, it's something I think we take a little bit for granted in a typically developing child. It's sort of what makes an older infant or a toddler such a delight, because it's that sort of wide-eyed sharing of what's exciting to them with you. And it's critical for them to have joint attention because they're learning about the experiences of others by looking at others for their reaction. And so when a child doesn't have joint attention, it just speaks to the fact that other people in their world may not have the importance that they should. And joint attention may not be totally absent in children with autism. It may just be weaker or inconsistent, but certainly it's one of the red flags. So a 12-month-old should be pointing, should be responding to his name. Joint attention really does develop between 6 and 12 months. It should be pretty consistent by 14 months. So if you're asking or looking for joint attention at 18-month-old, it really should be present. And then a 24-month-old, oh my gosh, how much they have developed. They can imitate, they have a lot of excitement, interest in others, and this desire for attention, you know, tugging on you, look, and really trying to draw others into their world. So I have several videos at this point, and it's a little bit different because I know you guys are on chat, but I would love for you to be sending some of your observations about these children that we're going to look at in the videos as we're going through them. And I may show some of them twice so that we can really emphasize what we want to in these videos. I bet you smiled, didn't you? Because he smiled at you. And so here's a really great, typically developing 12-month-old. He responded immediately to his name with eye contact. He was able to mesh that with a gesture of pointing at you with interest. He actually even showed joint attention when he pointed and looked at you. I think he's pointing to the person with the video camera. And so I'm just going to play it one more time because he's cute, and also that will give you an opportunity to comment if you would like to. Kyle actually looked at you, pointed at you, and this time I heard it a little better. There was a vocalization there as well. So he did a beautiful job meshing all of those together. The next video is a little bit harder to watch. This little guy, 18 months old, named Evan, and we're going to see Evan. Oops, sorry. Let me go back.
You want to try to see if you can get him to respond to it?
No. Mm-hmm. Evan. Evan. Evan.
See maybe if you can get him to respond to you now, you can use touch with his name, like give him a little tickle or something.
Evan. Evan. Evan.
He likes the tickles, but he's just not giving you too much eye contact, but he does smile when you tickle him.
Evan. Evan. Evan.
So I know there's some lag in our technology, but I really would like to hear from you guys what you saw that time. I know many of you are early intervention providers and therapists, and you've seen little guys like Evan. So I'm curious if you have any comments. And I'm going to play the video one more time and give us a chance to have some of those comments come in.
You want to try to see if you can get him to respond to it?
No. Mm-hmm. Evan. Evan. Evan.
See
maybe if you can get him to respond to you now, you can
name.
use touch with his name, like give him a little tickle or something.
Evan. Evan. Evan.
He likes the tickles, but he's just not giving you too much eye contact, but he does smile when you tickle him.
Evan. Evan. Evan.
So I think we have some comments from you guys.
Yes, so a couple of people that said no eye contact, no response to touch, limited eye contact. That's been key. And then I think just for me, looking at the mom, pretty disheartened, that her child didn't respond to her name. He withdrew from her touch was another comment. No facial expression.
So this is just what we're looking for. These are great responses. He didn't respond to his name, as you saw, and even when there was a physical prompt, he didn't really respond. Also, he's 18, 19 months old, and he's playing with the block by chewing on it, which is really immature play for a 1.5-year-old. A couple other comments, and this brings the point up that we really need to test hearing in these children. Whenever we do assessments and autism is a concern of the family or the EI team, of course we want to make sure that children have normal vision and normal hearing, because clearly that's important if you want a child to be responding to verbal sounds. Another comment I'd just like to make is that the therapist working with this mom and little boy ended that little scenario on a positive note. Even though it was hard, he didn't respond to his name. She sort of helped mom realize that he was smiling with the tickles and that he was responding positively to her. And I see you guys do that so often when I travel out into the communities, and I'm just really, really grateful for that support for parents. I have more videos. So let's look at Noelia and see what we think of her.
You see? And the doggy is saying hi to the bear. Okay. That's it? No more? No more? Look it. You see? And the doggy is saying
Lovely,
hi to
subtle
the
shifts
bear.
of her eye gaze
That's it?
between
No
her
more?
mom up
No
to
more?
the
Looky.
camera. She's 15 months, and she just really has very effectively created this circle of communication with her mom, her brother, and also included the person with the camera. So I think that's a really lovely example of joint attention.
Mm-hmm. And people have made the same comment, that she's painting with her family, pointing with her family, looks at mom for cues, vocalizing. She's looking at looking for a response from her mom and siblings. She looks back and forth.
Right. She looks back and forth, that sort of back and forth, involving other people in something she's enjoying. So let's again think about that joint attention and some of the other features that we want to recognize when we look at Evan again. They give you a little hint about inappropriate play. So
That one doesn't have anything that's hot. Let's go. It's for you, Evan. It's for you. Hello. Hello? Oh, you want to talk to Evan? Here you go.
So I imagine you have some comments about this one. I know phones don't look like this anymore, but kids still somehow seem to know that you ring the dial with your finger and you hold the phone up to your ear and you look at your mom as you say hello or oh or some approximation of that. So there really was a lack of joint attention or social engagement. He's really not playing with his telephone sort of appropriately. He doesn't have the pretend play yet, even though his therapist is doing a really nice job encouraging appropriate play with it. Other comments from the online?
So one person said more interested in the toy phone than the therapist, lack of imitation. Several people have said that.
Mm-hmm.
No imitation even after prompted.
I really, really like that comment about more interested in the toy than the person, and that's a pattern that we see often with children who end up with this diagnosis. Is they're much more interested in the toy than the people that engage with them around the toys. I think I'll just show it one more time, and I really like Fauzia's point from before. So watch mom's face when you get an opportunity to do that. The right one. No. You can see that mom's little.
That one doesn't have anything that's hot. Let's go. It's for you, Evan. It's for you. Hello. Hello? Oh, you want to talk to Evan? Here you go.
So the ACT curriculum has actually provided a lot of videos. I just chose perhaps 6 or 7 of 15 or 20 that were available for this module. And so there is also some link information if you want to go watch others of these videos. I just think that they really put together some very nice, vivid examples for us today. And I guess a picture is worth 1,000 words, so I guess a video is worth even more than that. Let's just take some more comments.
So there's one person that said, is there any concern with positioning, such as with the first kiddos? They are positioned face-to-face, but with Evan, he's shifted away from whoever is directly interacting with him.
Yeah, that's a really nice observation, too, that he's averting his gaze. And often we'll see kids in our evaluation room that will go to a more protected part of the room or turn their back to the people who are working with him in the evaluation. So I think that's a really nice observation, and that would be something for us to look for in the next videos, too, as we're going through.
Yeah, and several people have noted that the mom is visibly upset and overwhelmed. She's pretty frustrated.
She, you see her put her head in her hands right at the beginning when he kind of slams the phone, and so I think it's important to check in with these parents as well.
Do this. Look at me. Very nice. Lydia, look at Shauna. Look at me. Look at me. Look. Lydia. Look at Shauna.
So again, there's that great observation from before. She's actually averting her eyes away. And then when the person working with her averts her eyes, that's when Lydian actually looks at the person. And you can see that it takes a lot of physical prompting to even get a little bit of engagement from Lydian. Any comments?
Yeah, but even then, she's pretty hesitant to make eye contact, even when she's touched. So she kind of avoids mom's gaze, even turning her head away. So let's see. I think this is...
So this is a little 14-month-old that should be
1, 2,
a little different to watch.
3, 5. 5. Four little kittens. 1, 2, 3, 4. Nice little kittens. Look. Bunnies, 5, cabbages. 1, 2, 3, 4. 5. Cool.
So, let's see. I guess I'll play it again while you guys send some comments.
So people are saying he's smiling, looking at the book, pointing, definitely wanting to get done with that book. A verbal invitation.
5. 5.
And there's that joint attention, right? So nice
4 little
to see.
kittens. 1, 2,
definitely interacting with the camera person.
4. Nice little kittens.
I really like that the baby combines
here
a gesture and a verbalization together.
1, 2, 3, 4.
Sometimes we don't notice that they do that, but it's nice to see them mesh those together. So Caitlin, looks like she's doing pretty well. She has lovely imitation, nice engagement with her mom, and just that joint attention that we're looking for. So, back to Mark and his shy temperament, and this is actually a copy of handout 2 from what you have attached to your curriculum. So I'd just like to bring up some points in trying to sort out whether children are shy or whether it's consistent more with an autism spectrum disorder. And if you look at the features on the right, autism spectrum disorder features, those are actually some of the core criteria from the DSM, Diagnostic and Statistical Manual, 4th edition, text revision, which are the criteria right now that we're using until the DSM-5 comes out. And so this really speaks to those categories that we're going to highlight at the end of the talk, the 3 main criteria categories for children with autism spectrum disorder. But I think one of the things is that children who are shy in some environments and not in all environments. So they may be comfortable at home, comfortable with their family, but more withdrawn somewhere new or with new people. Whereas a child with an ASD, it's pretty consistent across settings. They will not, in any setting really, seek to share enjoyment, interests, or achievements with others. Children who are shy can be vigilant, so you often see them visually referencing their parents quite a bit, checking that their parents are close by, someone they know is looking out for them. Whereas a child with autism may not be as vigilant. They may cling to their parents, they may have anxiety, they may show a great deal of affection for their caregivers, which is lovely to see, and be comforted by their caregivers, but again, their eye gaze is often impaired. So you want to look for that social referencing. And then a shy child may take longer to become comfortable in a new setting, but then will participate, throw a ball back and forth, play peekaboo, share interest in a toy, whereas this reciprocity is markedly impaired in a child with an ASD. And I'm speaking broadly to behaviors. I want us to remember as we go through the cases that sometimes children who end up with a diagnosis of autism show the capacity to do some of these things, but not consistently and to the point that it impairs their social engagement with others. So here's a chance to say what you might ask Elizabeth about, what you might say to her. Just like your comments on what you might say to Elizabeth back at that case that we were talking about. So I'll give you guys a second to type in if you have a comment.
This is the mom from case 1, correct?
This is the mom from case 1. So Elizabeth is Mark's mom, your cousin, and we're going back to the case to say, you know, she gave you this history, he loves the fish tank, he has temper tantrums. What might you say to her?
So one person said, does your son try to show you the fish? Does Mark point to objects when you read, talk, or in new environments? Does he like to play with other kids?
Great. So all these questions speak to Mark's ability to have joint attention and socially engage with others. And I think we might take this opportunity to look at, if you would reference handouts 3 and handouts 4. These speak specifically to where Mark should be in his development and other domains of his development that we want to look at. So what would we expect from a 2-year-old in terms of other developmental milestones? I liked your questions about his social engagement, but what about language or play or other areas of his development? Mm-hmm.
Yeah, so one person said use and understand 50 words.
Great. I think that might be the speech therapist that's listening. Or maybe there's more than one. So right, and you guys have these in handouts. So use and understand at least 50 words. And a child with 50 words or signs in their vocabulary can combine words or signs. And so starting to put 2 words together in a very telegraphic way that makes sense, like want milk, go outside, mommy, those sort of two-word phrases.
Another comment is look for familiar objects out of sight when asked.
Great. So obviously they should have object permanence, and they should be able to understand your verbal directions to the point of, can you go get me a diaper? They should be following some simple directions. Bring me a book, throw this away. Other comments?
Does he pretend with his toys?
Right, so this emerging pretend play, is he playing with his cars in a way that is imaginative? Is he feeding a doll? Is he building something? Is he playing with more than one action, like putting a doll to sleep and feeding the doll? And can he do some pretend play, like use a crayon to represent a baby bottle or a block to represent a snack? Does he have some imaginative play? So these are all great. And they're also summarized in the handout entitled Your Child at 2 Years. So I think you can review these on your own, but I want us also to remember that children develop language and communication skills, and there's a wide range of normal for toddlers. So I think it's important to sort of to look at all domains of development when we're looking at what's going on with the kiddo. You can also see some of the motor skills are highlighted here. He should be beginning to run, climbing onto furniture, throwing a ball overhand, starting to do some fine motor skills, and copying straight lines. So you can see his motor skills, cognitive skills, language skills, and social emotional skills sort of summarized in that Your Child at 2 Years handout. And then the temper tantrums. You know, I think we need a little more information about those. So we might ask Elizabeth, and you can look at handout 4. These are some features of temper tantrums that are sort of beyond the norm. Clearly, when we hear the history that families haven't taken their kids out in months and months because they just can't deal with their behaviors away from their house. I know you all know families who are afraid that CYFD is going to get called because their kids are having such bad temper tantrums that the neighbors suspect abuse. And so this can really, really impact families hugely in terms of the whole family dynamic, the stress to the family. I imagine there's some comments about this. Anything online?
Just your last question.
If I could just jump in real quick, just a technical issue that we're having with our website. It looks like the only handout that we have at this point still is the slide set that you're watching now. We had some problems with our website, and we're going to get our the other handouts up on our site by the end of the day. It looks like I just got a note that the problem is fixed, but we need to upload the handout still. So apologize for that.
Well, I'm sorry I've been referring you guys all the handouts that you can't read, virtual handouts. But I think when we get to the handout that's early warning signs of autism, the red flags, I'll just go through that and read it point by point anyway. So the last question, what are the strengths of this child and family? I think it's always so critical, and I know that you, early intervention agencies, are very, very good and diligent about identifying the strengths of the child and the family when you see them. So I don't know if some of you have feedback about what you think are the strengths of this child and family.
Yeah, one person said mom is obviously involved, and it sounds like they have a good support system, which is good to see. Mom is definitely concerned.
So I would just add to that mom's perception of Mark back on the case page that we read is that he's an affectionate and happy child. And for a parent to see their child in that positive light is great. It's often hard when you hear that parents describe their children as bad or just being purposefully misbehaving. Which they can do, but it's just delightful that she describes him as affectionate and happy. I think some other strengths are obviously, she went through all this fertility work, so this is clearly a very desired child to this family, and that it's an intact family, mom and dad, with resources and the curiosity and concern to really figure out what's going on with Mark. So I think those strengths are important. I'm going to move a little bit more quickly. My goal was to finish the sort of didactic and video part by 1 o'clock for those of you that need to sign off at 1, and then use some more time at the end if there are other questions or observations, or even if you guys want to watch any of the videos again. I'm happy to stick around till 1:30, but I thought I would try to get through the core by 1 o'clock. So let's go through the case study part 2. During your conversation, you find out that Mark attained his motor milestones typically. So that's good news, right? By 1 year of age, he was walking. Now he is climbing on everything. He has started to repeat words, and thanks to a beloved Dora the Explorer DVD, he has learned many of his letters and can count to 10 in Spanish. You ask how Mark communicates and gets what he wants, which was a question that one of you guys brought up, I think. Elizabeth says that he is very smart and that he usually tries to get things himself. She cannot recall of a time that he pointed or gestured to get his needs met. At that moment, Mark wanders into the room. He starts to run back and forth while verbalizing, fast, fast, fast. You call him many times, but he does not seem to hear you. Elizabeth says that he is a very busy, active boy, and he acts this way a lot. He stops his playing and begins to spin the wheels of a toy train. You are beginning to get concerned. These aren't normal play behaviors. You even think back on your family history and can't recall anyone with autism. So now we're worried, and I would love to hear from you guys what among those behaviors were some of the red flags that we've been talking about today.
Okay. So one participant said Mark is displaying repetitive behaviors, is not responding to his name even after repeating his name several times. And several other people have said the same thing, not responding to his name. The train, that's concerning.
Right, so he's focusing on a part of an object rather than playing functionally with the object. I think there's also sort of an oblique reference to his beloved Dora the Explorer DVD. Sometimes when we end up seeing children that do end up with an autism diagnosis, and a lot of kids are attached to DVDs, no doubt, they have their favorite DVDs, but when we see kids whose language consists entirely of what we hear on a video or a TV show, that's not typical. And one of the case examples that they use in this learning module is this sort of scripted speech, like a child who is really obsessed with SpongeBob SquarePants, and you say, "How are you doing?" And the child may say, "Don't worry, tomorrow we'll be back for more frolic and fun." Well, that's a really long sentence for a 2 or 3-year-old, but it's a scripted, memorized sentence from a TV show, and it's not very functional in terms of getting their needs met. We had one family that came in, and almost all of what the child said or understood was from Yo Gabba Gabba, which I've never watched, but I think we do tend to hear this in kids, that sort of, they'll say parts of a book or parts of a song, and so they have the right number of words. They have 50 words, or they say 2 words together, but their functional language is not serving them to interact with other people. Comments from you guys?
One of the participants said fast, fast, fast is typically heard on Dora.
Oh, really?
Yeah. So
thank you for the Dora consult.
Can we switch back to the case? A couple of people have asked to look at that again. He's not communicating his wants or needs. Verbal scripting. Not referencing to get help when he needs something.
Right. I think so he's not pointing or gesturing to get his needs met. And so we hear stories of kids who move the chair over to the counter and climb up on the counter and get what they want themselves, because that's easier than going to their mom and saying cookies or juice and asking for help. So these kids are often characterized as very independent kids because that's how they get their needs met without other people.
And then one person said he is high functioning.
So, again, to go back to the strengths of the child and family. You know, Elizabeth perceives him as smart, and it looks like he's a pretty bright kid, right? He learned his letters. He can count to 10 in Spanish. So this is encouraging that he has language. He is learning. He is using some language, even if it's not very functional. And we would hope that he would function at a level. I have let's see what's next. I think we've sort of talked about some of these things as we've been talking about the case. Appropriate play skills for Mark as a 2-year-old, again, would be to be using objects symbolically, using the toys completely rather than being preoccupied with one part of a toy like the train, and excited about the company of others and with a lot of imitation, and so we're not seeing that with Mark. The concerning aspects of language, whoever commented that fast, fast, fast is from Dora, so that's scripted speech. We talked about what we would optimally like to see a child of 2 doing in terms of language. I think some other speech patterns that sometimes we see in clinic are echolalia, and I'm going to show you a video of echolalia. Echolalia can be immediate or it can be delayed and sound more scripted. And then using words out of context, and these are called sort of pop-up words. And another thing that we'll often hear from parents is that their children may say a complete sentence or a phrase, and then they never hear that language again. Or they learn a new word and forget it, or they only use a word but they use it out of context. So atypical language development. And I think you guys did a great job picking up the red flags in his language, social, and behavioral profile. So before I show you the next videos, and I'm sorry you don't have the handout yet, but you will. It will be handout 6. And I'm just going to read through it. I think it's pretty important. And each of these areas are the 3 main areas that we use from the DSM-4 when we are looking at a diagnosis of autism in our clinic. So some of these are red flags. Again, in isolation, we certainly wouldn't want to label a child or jump to a diagnosis. It's a very complex constellation of behaviors that we put together when we make the diagnosis. But we look at 3 major areas, and we've discussed and touched on all of these today. First is impairment in social interaction. Second is impairment of communication. And then third are these repetitive behaviors and restricted interests. So to go back first to social interaction, things like inappropriate gaze, lack of warm or joyful expressions, lack of sharing interests, lack of understanding contextual cues, lack of response to name, and lack of nonverbal communication. And then that goes into communication as well. Children who aren't showing, who aren't pointing, who have unusual prosody, which is sort of the melody of speech. Any of you speech therapists who want to weigh in on prosody for me. Lack of communicative confidence, and using a person's hand as a tool. And this is really something that is startling when you see it, and I wish I had a video of it. But when children take their parents or an evaluator's hand and put it on a toy to activate it, put it on a door handle to open it, put it on a jar to open it and unscrew it. So they're really using their parents' hands as a tool. Another thing about communication to be aware of is something that we think of as hyperlexia. And hyperlexia is a toddler who can sort of, quote, read. So this can be just precocious development. Maybe you have the next, genius. But if they are reading and repeating letters and numbers and things like this to the exclusion of more typical play, then we're concerned about that. So these are children who may have huge numbers of words in their vocabulary, but again goes back to that functional language piece. Lastly, the repetitive behaviors and restricted interests. So these are kids who are may have a particular routine. They're very stuck in that routine. They become very upset if it's not followed. They may make repetitive movements with objects or posturing with their body. We'll see kids who flap, but more subtly they may twist their fingers. They may use their peripheral eye gaze to look at things. Lack of playing with a variety of toys, so they're just stuck on one toy or playing with a toy one way. Or they have unusual sensory exploration of toys. They lick toys that aren't meant to be licked. They smell things that aren't meant to be smelled. Or excessive interest in particular toys. And we often see toddlers who are attached to an object, but then sometimes we see kids who are on the spectrum who always have to carry something in their hands, whether it's their cars or something specific, to the point that they sleep holding these things. They're late crawlers because they can't crawl holding something in their hand. So really sort of look at how is the behavior impacting the child and the family. Lastly, we look at emotional regulation, and this isn't included in the DSM-4 criteria, but it certainly speaks to how well a child is sort of functioning in their world. Distress over removing objects. These kids are very hard to calm. They're sometimes labile and shift in their emotional states and just unresponsive to interaction. So I went through these really quickly. Again, they'll all be on your handout. And I'd just like to show you some videos now before folks have to go. So these are twins, and just so curious to hear your impressions of these two twins.
That's right. Here it is. Uh-oh. Go! Push. Good boy. Ready, set, go! You can push. Stay up here. Stay up here. Go! Stop. No. Nathan. Go! Look, here it is. Keep the train. Stay up here, please. Good boy. Ready, set, go! You can push. Yeah, it fell.
So comments that people are making: reciprocal play with the truck, good joint attention, second child wanting to play independently rather than with mom, and the first play back and forth with the mom, good eye contact, and shows no facial expressions.
So this is just what we're looking for in the context of those red flags for autism. Ben is making eye contact. He's got nice joint attention. He has reciprocal back and forth play with the truck, pushing it back and forth. He stays in the communicative engagement. He vocalizes in the context of the play. These are all, lovely skills that we see. Then Nathan, on the other hand, seems really to want to escape the engagement. He's turning his back to his mom or the therapist, I'm not sure, and it's really hard for him to include her in his play with the truck. He's not really playing with the truck typically, not really rolling it. So I'm going to show it to you one more time. I've watched it a lot of times, but I think every time I see it, I see something new with these kids. So I can't find it. So we'll just watch it one more time, and if you guys want to make any more comments, they're very welcome. nice
off.
imitation. He looks to her.
Here it is.
Off. Again imitating.
Uh-oh. Go! Push. Good boy. Ready, set, go! You can push. Stay up here. Go! Stop. Nathan. Go! Look, here it is.
Another point that someone
Yeah,
noted
please.
is Ben was verbal during his play, whereas his sibling is not.
Right, great. So Ben was verbal. His sibling was really quiet. I don't know if anybody has asked this or commented about this, but the genetic component of the question of autism comes up frequently, and there's really broad-ranging studies, but between identical twins, across studies, there's a 36 to 95 percentile concordance rate, which means if one child has it, there's a 36 to 95% chance that the second identical twin will also have autism. Among non-identical twins, the studies range from 0 to 31%. But I think this wasn't really in the module, but as a pediatrician, I think it's really critical and goes back to early detection because we know that a family has a 2 to almost 20% risk of having a second child with autism if they have a first child that's affected with autism. So we know the risk is much higher to have a second child. And a lot of families have that second child when the first one is, 18 months to 2 years old. So if you're picking up on this diagnosis, you can give this family so many more options in terms of genetic testing, early detection, family planning, so that they're making their decisions with the knowledge that their risk is higher to have a second affected child. So I wanted to include the twins just to remind me that it's important in terms of counseling families. And the earlier we find it, the more chance they'll have the knowledge before they have more children. I'd just like to have you watch Echolalia. This is a beautiful little boy. He's 2.5, and he seems very bright and very happy, but I want you to look at how he at first disengages with the therapist and to notice whether he initiates any engagement, because initiation of social interaction is really, really hard for kids with autism.
Say no, say hi, Georgia. Hi, Georgia. Give me a hug. Come here. Come here. I gotta tell you something. Hi. Give me a big hug. Oh. How are you? Fine. I'm fine.
I'm fine.
Good. Are you playing?
I'm fine.
Oh, it's cold, look. Ooh.
So again, you might look at this little kiddo and he seems pretty engaged, but she needs to physically touch him. In the beginning, he turns away from her, and his language is completely echoed with the same intonation, the same question, the same lilt, as the therapist uses. So just another example of a difference in communication. So this is the epilogue for our case. We've sort of reviewed in our minds that what Mark is showing us is not really typical, and we commend Elizabeth for picking these issues up so early. And she becomes teary, and she admits that her sister thought it could be autism, but she wasn't sure. So why was this missed? And here's the point, that those of us who work with children, or especially little ones, are in a position to make these valuable observations and take them seriously, learn the signs, and refer early. So This goes back to you guys as far as how would you apply the information from these cases, or if you learned what you hope to from these cases, this case specifically. And then the next slide is a post-learning exercise. There's a link to the CDC to just really brush up on developmental milestones for each age group so that you'll recognize when they're not meeting those milestones. Any comments or questions about the case?
One comment participant made was Elizabeth missed the chance because of Mark's ability to function overall. I understand that clearly.
So he's, Elizabeth missed the chance. Well, you know, I think what the next module is about is the MCHAT, which is the Modified Checklist for Autism in Toddlers. So I feel like there's some merit to that, but I also feel like Elizabeth brought her concerns to her healthcare provider. And now the American Academy of Pediatrics recommends the MCHAT screening at 18 months and then again at 24 or 30 months. And the reason for the second screen is because some kids show regression in that late second year. So we pick them up with the second screen. So I wonder if Mark had an MCHAT, if some of those more subtle communication problems like not pointing, not gesturing, not sharing engagement would have come up and led to his being referred for an assessment. So I feel like she tried to communicate that, and it's our job to hear, because of course we always say parents are the experts on their children, and so we need to hear what they say. Thank you for the comment.
A participant asked, what's the MCHAT?
So the MCHAT is the Modified Checklist for Autism in Toddlers, and the whole second module of this autism case training is devoted to the MCHAT and the follow-up interview. The MCHAT is a screening tool that's used to detect some of these more subtle signs of autism spectrum disorders. It's available in a number of languages. It's free to download, and there's just a lot of great information from the MCHAT. So it's the probably most accepted screening tool for autism at this time in toddlers, in preschool age kids. Thank you for the question.
There was another participant that said, I think the handouts will be helpful for families to see. For example, the one that compares shy children versus children with ASD.
Mm-hmm. I think so too, and sometimes we are referred children who are just very, very reticent children. You know, there's a huge differential diagnosis for this kind of shy or restricted behavior. Are these children who have been neglected? Have they been abused? Have they had a lot of foster placements? Have they had illness and been in the hospital a lot? There are so many things that contribute to the psychology of a child that one behavior alone certainly can't be evaluated, you know, in the lens of autism. But I think if a family's worried about autism and you feel like you can reassure them, then that might be a helpful comparison.
One of the participants said there's a great iPad application for the MCHAT, and that's the first time I've heard of this.
I haven't heard
really
of it either,
cool.
so as soon as we finish, we'll be looking that up. Thank you.
Yeah, send us
great
information.
So you can, I guess, look on iTunes for the MCHAT app, I guess.
Yeah, that's really great. One of the participants said, thank you for sending a link which includes all developmental milestones. I think healthcare providers should all have developmental checklists available for parents to fill out at each visit to pick up on red flags, especially first-time parents.
Right, especially first-time parents, I think, and parents who are not necessarily growing up with their family. I think it's really hard when you don't have cousins or parents to help you gauge what's normal or typical development. And this is my chance to put in the plug for the ASQ, the Ages and Stages questionnaire, which is promoted through DSI and is very helpful in looking at all these domains of development and pointing out when kids are behind. I think as early as 4 months, right, Fauzia?
It starts from 1 to 60.
1 to 60?
Yeah, it's a huge range. We just looked at up the app for the MChat, and it's free.
Yay!
So you all know. Several comments about the ASQ. And we will be happy to forward you that information about the developmental screening project. There's more information on our website as well, so I want to refer you back to that because that'll give you more information. If you're a provider within New Mexico, you're more than welcome to join that project free of cost.
I would love some feedback about the videos. If you feel like there are too many videos or you feel like you would like more videos, I would really welcome some input about that as well.
Yeah, they said more videos.
More videos.
The videos were excellent.
Good. I'm glad we included them.
They were very helpful, extremely helpful. Yeah, definitely in getting the point across. I think being able to see it. And there's a question about when the next webinar will be. And right now, we'll just say stay tuned. It'll be soon. We will send out information. All of you all, as participants now, will get emails from us about the upcoming sessions. Okay.
And you can always log into envisionnm.org now that our website has been fixed. Go to the calendar and you can see all of our events coming up, including DSI sessions. There was one question about what the iPad app was called, and it's M-Chat Autism Screening Tool. If you search for M-Chat, you'll find it.
And it's all caps generally.
Right.
Mm-hmm.
Act early / milestone / index /
Yeah, so there was another comment from somebody about the ASQ, the range being from 1 to 5.5 years, and that's correct. 1 month to 5.5 years. Yeah. So there is one comment about storyline. Storyline was somewhat lost in the beginning with all the videos. Suggestion: add photo of Mark and Mom on pertinent slides as a visual reminder.
Oh, that's a good idea. I know it was quite a while between the first part of the case and I was so hooked on the videos, I used quite a few of them.
Yeah, I'm not sure if there was a video with the case number 1.
We could find a nice picture, though, of a 2-year-old.
Yeah.
So you would keep them in your mind.
So there's another question about the difference between the ASQ 3 and the ASQ SE, social emotional. Would you like to answer that now or just defer that until later? We can email you information if you'd like.
That would maybe be helpful. I haven't used them in practice the way I think all of you that are enrolled in DSI have used them. So that would be a good one to look up and email.
Several people have commented about the time. So for future reference, these are live from New Mexico, so it's Mountain Standard Time, and so there will be a time difference for you all, and we really appreciate everyone that's connected on because I don't know what time it is for you all on your end, and we're definitely happy to send you information if you need that in future. This will be recorded, the audio version of it, so you should be able to see that on our website soon.
With the handouts.
With the handouts. With the handouts. You can also go to the CDC website as well, and there's a link on one of the slides to go to that. Mm-hmm. It's fairly comprehensive.
I don't think we actually have the link for the ACT on any of these slides, but if you Google autism case training and CDC, the first thing that comes up is the entire curriculum, all 6 modules, with a lot of videos. as well as the handouts, even the PowerPoint, although I've tweaked the PowerPoint just a little bit. It's all online, and again, it's all able to be copied and distributed as long as you credit the people who put it together.
And what were those keywords again to Google?
Autism case training and CDC.
Thank you.
Mm-hmm.
Several people have said thank you very much. Very informative information. There will be a certificate, CME/CEU certificate that's going to be sent out to you. We do those quarterly, so I'm not exactly sure when you'll receive it, but hopefully the end of December is when you should get that, and it'll be sent via email to you. So if there's anybody on the line that did not register or is sitting in with a bunch of folks, please do let us know. Send us an email, and that email would be Clancy Tarbox. Okay?
So that's ctarbox@salud.unm.edu.
We have a question here. I would like to know how to effectively redirect a child or how to help child handle temper tantrum.
That is the million-dollar question.
Right.
And, I work with so many talented therapists, and I think temper tantrums are so hard. The first thing I think to do is not go in a situation that promotes the temper tantrum. So don't take kids to Walmart. Don't even take typically developing 2-year-olds to Walmart where they won't get M&Ms at the checkout. But as far as redirecting during a temper tantrum, I think that's really hard, and it's going to be case by case, and we can talk more about that offline if you like. I just think it's probably too big for right here. Do you want to write down who asked, and I can call them?
Yes, we will have everybody's contact information, and we can contact you. You can also leave comments for us when you sign off, and we will send that to Mara. There's one person that said, from our experience, early Head Start, doctors are not completing them. Would you recommend we do them? Not sure if this is referring to developmental screening or the MCHAT. So this is somebody from early Head Start.
I know that some of the early intervention agencies do MCHATs. I don't know about Head Start. I think if you're, and this is just me, I think if you're comfortable doing it, if you get comfortable with the follow-up interview, but you also have to be really comfortable talking about it if you end up having concerning results. I do think that these modules sort of take you through that sequence of administering the MCHAT, becoming comfortable with the follow-up interview, and then actually talking to families about autism as a potential explanation for their kids' behaviors. But I think it takes a lot of training. I don't know that it matters what degree you have or what environment you work in as much as just that you're really comfortable with the tool and comfortable with giving the information if you should have a child that needs to be referred.
There's a question about, in New Mexico, is there a difference between medical and educational diagnosis of ASD?
My understanding is that there is, because I know the kids get sent to the Center for Development and Disability for those diagnoses as a medical diagnosis. I've seen kids who have already received the educational diagnosis and the families are there for the medical diagnosis. I don't know if someone else is online who would want to speak to that question. It may have to do with the DD waiver. Again, I'm not exactly sure why they need the distinction, but I know that we do see a lot of kids who need the medical diagnosis as well. There may be someone else online who can speak to that better than I can.
Yeah, one person said in education it's a classification of the diagnosis, and the diagnosis is only given by a psychologist or a physician. also a medical diagnosis helps with SSI.
Mhm. So that's a really good point. All these families where we make a diagnosis are referred for SSI and then to apply for the DD waiver or D&E waiver. So we never rush to make a diagnosis or to, families want to avoid the quote label and quote of autism, but it does certainly open up a number of resources, both financial, educational, and behavioral for the families.
One attendee said, in my experience, it's easier to get a medical diagnosis than an educational one. Our program, ESEP, sees kids 0 to 3, and we travel around the state, and we are delighted to see kids where this is a concern. There's the neurodevelopment clinic at UNM that has a longer waiting list than we do. I believe it's 6 to 12 months. They don't travel, and they see kids at least through 18 and maybe even a little bit older than that. And that would be the referral source, the neurodevelopment clinic at UNM CDD, if you're concerned about autism in an older child. There's one comment, the only EI practitioner that can diagnose autism is a licensed psychologist. And that's my understanding also, that it has to be a psychologist or a medical doctor to make the diagnosis. We're lucky in the ESEP team, our team consists of a child psychologist, a speech therapist, a motor therapist, and a pediatrician. So we really have a multidisciplinary team. Really a delight to work with a team like that. There's a reference that one attendee gave about temper tantrums, Happiest Toddler on the Block by Dan Siegel. New parenting book and spirited child books can be helpful for all children, ASD or not, as they address sensory and individual temperament differences. There's a reference book that one of our psychologists often recommends too when there's concerning behaviors. I think it's called SOS for Parents. I can forward the information to Fauzia to put on the website about the author and the book, but there's a lot of great information in that book as well, SOS for Parents. Have you heard of it, Fauzia? No, I haven't, but it sounds familiar. There's another person that says licensed social workers and mental health providers are licensed to diagnose as well. That may be, I don't know. Yeah. I'm not sure if the rules are different in each state. The SOS Help for Parents is by Lynn Clark. Thank you. Thank you, whoever. We're getting really fast comments from you all, which is great to see. And one attendee said not all mental health providers, so I guess they have to be licensed LPCCs. Any other questions you all have for us? As you can see on the slide, the next module will be screening for autism. So as soon as we have information about the dates and the time, we will send that out to you all. Okay. Well, I'd just like to thank you all for participating and also for inviting me to present the information. And again, my contact information is on one of the slides, so please feel free to get in touch with me if I can be helpful to you. Thanks again. Thanks.